Good evening, everyone. Thank you all for being here. I'm really privileged to be amongst you. And thank you, UFHealth, for the kind invitation. And to my mom, my hero, she's also in the audience, by the way. But I'm here actually to talk to you about a very important subject I'm very passionate about just because it affects so many women worldwide. Over 200 million women are affected by endometriosis. And it's really important to have an early diagnosis and management. Endometriosis can affect up to 15% of reproductive age women. And that, like I said, that's over 200 million women worldwide. It's a chronic inflammatory condition. It involves endometrial-like tissue outside of the uterus. So it's a very painful condition. And it affects half of patients with infertility and up to 87% of patients with chronic pelvic pain. In 2000 alone, so that was over 10 years ago, the US spent over $49 billion on endometriosis care. A lot of it was loss of productivity. These women were missing work every single month for sometimes a week. They had a lot of failed management that, it wasn't recognized. They would go to 4 or 5 different specialists because they had a urologist for their bladder pain, a gastroenterologist for their bowel pain, a gynecologist for their uterine pain. So they were kind of, lost in the system, and this causes them to also, oftentimes have a lot of anxiety, depression. They have a lot of psychiatric disorders. So it's a disease that really affects the quality of life of women in a huge way. There's increased risk in women who have early onset of their periods, late menopause age, if they have certain pelvic organ anomalies like Müllerian anomalies, and women who have first-degree relatives like mom or sister that have endometriosis are more likely to have endometriosis as well. There's a decreased risk seen in women who have more children and who have increased breastfeeding time, so another great reason to breastfeed. This is sort of a very busy slide, but it gives you a sense of what an endometriosis patient may look like, whether it's yourself or someone that you know. Usually, they have a family history. They have a history of missing a lot of school days, high school, middle school. They had to stay home a lot because everything that they tried failed, including anti-inflammatories or oral contraceptives. They usually have menstrually related painful bowel movements, painful urination. They have a lot of painful sex symptoms. They have menstrually related diarrhea and constipation. They, most of the time, have some other chronic inflammatory condition, whether it's Crohn's disease or ulcerative colitis. And a lot of them, unfortunately, have a lot of trouble getting pregnant. And if they do get pregnant, they have adverse perinatal outcomes and, unfortunately, miscarriages as well. A lot of, even providers, unfortunately, don't have the information that they need to diagnose women, and it's really not to their fault. There really aren't any good diagnostic tools that exist currently. And so women go sometimes 10 years without a diagnosis, and again, sort of ties back into the chronification of endometriosis and their painful symptoms. Infertility couples tend to conceive 10 times less than patients who don't have endometriosis. So that's another reason that these women suffer, a lot of them in silence, and don't like to talk about it with their families. Unfortunately, we don't know why endometriosis occurs, and we just know that there's a lot of chronic inflammation in these patients. So a lot of chronic molecules like prostaglandins, and estrogen is really a driver for endometriosis. And so women in their reproductive years or in menopause, if they're put on hormone replacement, may get a reactivation of the disease. So it's very important to carefully discuss your endometriosis history with your providers. There's 3 main types of endometriosis. By far, the most common is the superficial type. And in the upper corner, you have a picture of the back of the uterus and the cervix. And below that is the bowel. And this is from a laparoscopic view or a surgery that can be done to diagnose endometriosis. And these superficial lesions are usually pinpoint lesions that are very, very inflammatory and very painful. And they can look anything like just black, blue, red dots in the cervical area. And a lot of times, if they're not diagnosed because they can be pretty subtle. Then there's the ovarian cystic endometrioma, which is a blood-filled cyst that can occur in the ovaries. And usually this is very toxic to the ovaries, and women have loss of their ovarian function over time with these cysts. These are the two main types of endometriomas, or of endometriosis, are the most common types of endometriosis by far. And then there's the deep infiltrative endometriosis, which usually has an appearance sort of like an iceberg, where there's very minimal changes on the surface of their abdominal wall or in their pelvic cavity where the uterus and ovaries are. And so again, it could be missed. And patients are usually very painful with this condition, and it's usually found either on the bowel or in the ligaments that support the uterus and the cervix. The diagnosis of endometriosis can involve non-invasive tools like ultrasound and MRI. Both of them are very specific and sensitive for deeper lesions or ovarian cysts, but they're not going to pick up the superficial disease. So a lot of women go to their doctor, they have the complaints for long periods of time, and they don't get diagnosed because our most sophisticated imaging tools can't pick up the disease. So surgery ends up being sort of the confirmatory gold standard for diagnosing endometriosis. Fortunately, in our OBGYN department, we have great sonographers that are also gynecologic specialists that are able to do high-level ultrasounds and are able to pick up most of the disease that can be seen on ultrasound. Recently, I had a patient who was 28 years old. She's had lifelong painful periods, painful sex, painful bowel movements, and her ultrasound was done at another center and it was completely normal. When I did her exam, I knew that I was likely going to find something that sort of indicated endometriosis, and behind her cervix was this blue-black lesion, and it was also extending into her rectum or her bowel. And so these are the patients that sort of get, missed for 10 years and never get a real diagnosis of why they're having their painful symptoms. The endometrioma is that ovarian cystic endometriosis lesion, and it can be seen in about half of patients. And again, it's going to be very, very aggressive to the ovary. It's going to cause scarring and loss of the ovarian function over time. It does sort of go along with the deep infiltrative endometriosis that we talked about earlier. So a lot of times if there's a very painful cyst that looks like an endometrioma, it's usually also involves the bowel. And a lot of patients are told that, this could be cancer. And I think this is true. The ovarian cancer risk is higher in patients who have endometriomas, but it's usually not in very young patients. So we always talk about, with the patient based on the individual factors that they have, but this is likely not cancer. We try to preserve the ovaries because a lot of these women are very young and they want to have children. So we want to preserve the ovaries if we can. Surgery is usually indicated for these ovarian cystic lesions if it's very painful and they're larger than 3 to 4 centimeters. And it is associated with higher fertility rates if these cysts are removed. And there's an increased time to recurrence if the cyst is completely excised. And there's also lower recurrence of the painful symptoms if the cyst is excised versus if it's just drained or sometimes just burned or ablated. And then medical treatment after the surgery is very helpful to prevent the disease from coming back. Adenomyosis, I like to call the fourth type of endometriosis, but it's really the same kind of abnormal tissue that invades the muscle wall of the uterus and causes the same very similar symptoms of painful periods and painful sex, very heavy bleeding. And a lot of these patients also have infertility. And so if we only treat the endometriosis and don't address the adenomyosis, then these patients will usually have a much harder time getting pregnant when it's time for them to conceive. So these are the patients that we send to our reproductive endocrinology specialists. Medical treatment is by far our first line of treatment for endometriosis because it is usually safe. It usually comes with very minor side effects, if any. and it's pretty well tolerated. It's not appropriate in certain patients. One of the patients that it would not be appropriate in would be if they have an obstruction of their bowel movements, if there's obstruction of the kidneys. And we have seen a lot of patients that the diagnosis of endometriosis is not made, and then they have a silent loss of their kidney. If they're actively attempting to have pregnancy, that's also not a patient who would be a candidate for medical therapy, because they wouldn't be able to get pregnant at the time that they're taking the medical therapy. And then if there's severe symptoms despite active medical therapy for 3 months, then it's usually not going to start working all of a sudden. So that's sort of the patient that you want to go ahead and send to a specialist that understands endometriosis and that can treat the disease, because the medical therapy just is not working. So some of the first-line medications that we use for endometriosis would be your anti-inflammatories, your combination oral birth control, progestins, which are one type of hormone that's in combination birth control. And then there's the levonorgestrel IUD, or the intrauterine device. These are all very effective for endometriosis-associated pain. And then there's sort of less commonly used medications that usually decrease estrogen, like danazol and the gonadotropin-releasing hormone analogs. All of these have more side effects, so I rarely use them in my practice, but there are some very severe refractory cases where it is indicated to give patients the option to use some of these, less commonly used medications. Surgery is very effective for patients, especially if they're trying to conceive at the time. This is something that can be done to treat their painful symptoms. And it also improves pregnancy rates with the excision type surgery better than just the ablation type surgery, which is just the burning of the tissue. Excising the pathologic or abnormal tissue is much more effective. And then there's patients who no longer want to have children and wish to go and have a hysterectomy, versus the patients that still want to keep their uterus and still have their endometriosis treated. And both are really effective, and it really is an individualized choice. And so we take that into account, and both at short term are both very effective. At long term, if we keep the uterus, the endometriosis does tend to come back about half of the time over 5 and 7 years later. The other important thing I wanted to point out is that we don't have to remove the ovaries in the patients that are young and have endometriosis. So if we remove the ovaries, it's usually because we think there's a cancer there, or in older patients that maybe their ovaries are no longer functioning. And then there may be like a benefit to removing the ovaries at that time. But we usually try to preserve the ovaries because it protects women against heart attacks and strokes, and early osteoporosis. Factors that can cause endometriosis from coming back would be if it's incompletely resected. So if the surgeon doesn't feel comfortable with the anatomy or doesn't understand all of the types of the disease, and it's not resected during the initial surgery. If there's microscopic endometriosis and it's not seen and progresses. And then if there's adenomyosis, which is that painful condition of the uterus in patients who keep their uterus. There's also a central sensitization component to patients that have chronic pain, where their brain makes very abnormal pathways, causing them to still have pain, even if the endometriosis is completely resected. So my take-home points are that endometriosis is a complex inflammatory disease. It's hormonally driven by estrogen and causes severely painful symptoms that affects the quality of life of many women worldwide. Fertility is a concern for most of the patients that are young, and so it's very important to have that individualized approach. And postoperative medical suppression is usually effective and recommended to prevent the recurrence of the disease. And I want to thank you all for your attention. I'm very proud and happy to be here with you guys.